Okay, so we are live.
We are live, Doctor. So we'll give everybody until about 3 minutes past to join, and then we'll turn back on.
All right, perfect.
Thanks, Doctor.
Hi, Danny.
Hi, Doctor. Good morning, everybody who has joined us. Thank you so much for joining us this morning. Um, I am joined by a very esteemed colleague and medical doctor, Dr. Omar. He's going to be taking us today through HIV in our world today. Some of the topics he's going to be covering are just really the basics about HIV, their risk factors. I'm going to be talking a little bit about testing, some treatment options, and some updates there. Some updated facts and figures about it in the world today, relating to COVID-19 as well. Then closing on some prevention and lifestyle changes that people could make. So please sit back and relax. Doctor, thank you so much for joining us.
Hey, thanks, Daniela. I see on the chat box that people are having an issue with the sound, or struggling with the sound. I just want an indication as to whether everybody can hear me or whether they heard the introduction. If they can just pop that into the chat box quickly or give us an indication. They're still saying still no sound. Okay.
Sound is all good.
Christina.
Alrighty,
No problem.
perfect. Thanks, Doctor. Over to you then. Perfect.
All right. Perfect. I just need an indication whether you guys can see the slides, and then we can start. Right. So good afternoon, everybody. Right. Thanks for inviting me. Today we've got a power-packed presentation right around HIV and stuff that you haven't heard. Right. In terms of where we are, right? How is it related to COVID-19? What are the new developments? And how are we going to tackle this? And how is South Africa as a country doing in terms of HIV itself? So I'll start off with an update on HIV/AIDS facts and figures. And then I'll tell you what are we doing right. And so this kind of epidemic has been going around for a very, very, very long time. So we need to know, right, what initiatives the countries, right, each country across the world, including South Africa, have set goals and whether we're meeting those goals. Right. And why we're not meeting them, right? Or how far are we and how far do we have to still go? Then I'll take you quickly through some basics around HIV, the risk factors, right? A difference between HIV and AIDS, how you progress to AIDS, some testing, the treatment options, and then we'll look at some resistance, right? And I think what's new about the social dynamics around HIV is that it has changed quite a bit. And we've also seen some changes, right, in terms of HIV, COVID-19, right, and some changes in terms of the prevention and lifestyle, right, that's had to be adopted. And I think it looks more or less kind of positive in terms of the progress that we've made. And then I'll take you through some concluding remarks, right, and I want to hear from you, right, around your thoughts, right, and some questions, right, around what you think about the topic, right, even outside of this presentation as well. So let's start. So the total number of people with HIV in South Africa, right, has increased from 3.58 million, right, to 8.45 million. Right, that's from 2002, right, to 2022. Right, and approximately one quarter, that's 24% of women are in their reproductive age, are HIV positive. Now, this creates a problem because if women, right, in South Africa in their reproductive ages, starting from age 15, right, are getting to be HIV positive, right, when a person becomes sexually active, they have many partners throughout those stages. And if they don't know that they are infected, right, they tend to perpetuate the spread of HIV between the partners. That's the first thing. The second thing is a pregnancy. If you don't know that you're HIV positive, right, and you're pregnant and you're not taking treatment to prevent the baby from getting HIV, then we further perpetuate, right, the number of HIV infections, right, and comorbidities, and the number of people that will die, right, due to HIV. So I think that's very, 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 very important, right, that we need to understand from the stats and the figures. We've grown proportionately to become, right, the hub of HIV infection, right, in sub-Saharan Africa and Africa itself, right, and we need to lead the way in terms of HIV prevention. Okay, so what have we done right? Now, from prior to 2002, right, we didn't have a robust HIV program. So the HIV program, right, was more or less run by non-governmental organizations, right, research organizations that were looking at prevention trials treating tuberculosis and HIV. Then eventually, right, as capacity grew and the price of drugs started dropping and became more affordable, and the political landscape started changing, that's when the HIV programs, right, and the rollout started happening. And part of that rollout, right, involved not only doctors, but involved moving the spectrum of healthcare to treat HIV from a nurse perspective. So the task shifting to nurse-based care started happening over time. The monitoring of HIV, the treatment access started improving over time. So South Africa, in terms of their key indicators, right, have made a promise to the World Health Organization, right, in terms of increasing the life expectancy. So we have increased the life expectancy, right, by starting ARVs earlier on. So as soon as you're diagnosed with HIV, South Africa has got a policy to start HIV treatment, right, immediately. And what this does is we're no longer waiting like in the past. In the past, you had to wait until your CD4 dropped below 250 to start treatment. Now you can start treatment right as soon as you're diagnosed, which makes it a lot better because you're able to control the viral load or the amount of virus in your body very quickly, right? And you're able to prevent the virus from spreading and making you more sick. So the life expectancy has increased, right? Because we're not getting so much more opportunistic infections, right, due to the early startment of treatment. Then we've managed to increase the ARV uptake, right, and adherence, right? So from 1 million in 2011 to 4.2 million in 2018. So this is by virtue of the number of clinics, the number of staff, the number of people that are treating people, right, and the simplicity of the drug. So as time has gone on, right, if you can remember in the past, right, we used to give three cocktails of three different drugs that you had to take twice a day. Right, and now we've got one tablet with all three combined tablets, right, in one that you take once a day. So that's made things a lot more easier, right, in terms of adherence, right? And we've got more clinics right now, right? And people are being screened readily. So the uptake is better. The adherence is easier with one tablet. So we've managed to successfully, right, increase the adherence. Right? The decreased maternal deaths, right, very significant because as a result of the screening programs in pregnancy, right, and starting of the antiretrovirals in pregnancy, or even before members become pregnant, right, we're able to prevent these maternal deaths. Now, that also has a knock-on impact on the infant mortality because by starting ARVs, right, you also prevent the baby from getting infected with HIV and subsequently developing opportunistic infections. And I think that was the problem, right, is that the babies, right, that were contracting HIV were developing tuberculosis, pneumonia, and other infections, and they were dying earlier on, either at birth or shortly after birth. Right? And then prior to right the introduction of screening of HIV and monitoring for in terms of the prevention to mother to child program, right, these infants were born and we didn't know that they had HIV because there was no testing. There is a specific PCR testing that is used for these kiddies because remember, when a baby is born, right, they have the mother's antibodies. So if you do an ELISA test, you're going to pick up the mother's antibodies. So you don't know whether the baby's infected, but right, you know that there's antibodies. So the only way to pick up right whether an infant right is infected with HIV is do a PCR test for them, and it's a DNA PCR, which is specific and different from an RNA PCR, right, in an adult to look for HIV infection. Okay, so we've managed to reduce that because we're testing the babies, and we're testing younger children now. Then the reduced number of HIV related deaths have also reduced quite significantly, right, by over 100,000, right, between 2009 and 2018, and this is because of the drug adherence, the increased access, right, and the simplicity of the drug. So the drugs are working. So the top line targets across the world, right? We looked at, right, creating a 95% of awareness and coverage, right, for members, right, across the world. So these are global goals. Right now, furthermore than the global goals, right, what were the targets outside of treatment? The targets outside of treatment was to also look at stigma, to prevent people from being discriminated against because of HIV. That was one. Number two was to increase the access and the awareness, and to stop the younger girls, right, from getting infection by bringing the education into the communities and into the schools, and creating that incentive, right, for young women to delay sexual intercourse, right, and then also use protective mechanisms, the contraception, right, start taking drugs, and also earlier on, and preventative, right, mechanisms, right, for prevention of HIV. And we've evolved even in the preventative methods, right, of HIV, that can now, right, reduce HIV quite significantly. And in an individual that's got HIV and they fully suppressed, the risk of them transmitting it to someone else is even a lot lower. So those goals and targets went beyond care and control, right, of the disease itself. It went all the way to the community, how we accessing the community, how we destigmatizing the stigma around HIV, right, including, right, how are we creating or eliminating the gender barriers, right, around HIV, and how many of the individuals, even with HIV, whether you're a serodiscordant couple, one has HIV and one doesn't have HIV, we've evolved to a level whereby, right, these same couples, right, can prevent infection, right, between each other. They can have normal families, babies also, right, during the that sexual intercourse, and prevent the child from becoming infected now a lot more easier now, right? So those access, and that access to newer drugs and technology now, right, has allowed a lot of that to happen even within the poorer communities. The only thing is that the advocacy, right, was lacking, right, and the access, right, and now that we're getting there slowly, right, we're beginning to see progress, right, along those lines. Now, to take you through what is HIV, right, let's take you through the acronym: Human Immunodeficiency Virus. YH is specific for human beings. If it's found in an ape species, it will be called Simian Immunodeficiency Virus. If it's found in a cat, it will be called Feline Immunodeficiency Virus. So the reason why we say it's human is because this is specific for humans. So the human can't transmit the human form of immunodeficiency to another species. I think that's quite unique. So with viruses, remember, right, when I come down to telling you about other RNA viruses that can hop from animals to humans, right? The HIV, the human immunodeficiency virus, can't hop, right, from a human to an animal, right? And that will be quite important, right? So it's a retrovirus, right? It's an RNA virus. So what do we mean by an RNA virus, right? And a DNA virus. So a DNA virus example is a flu. And now, to simply put the difference between an RNA virus and a DNA virus is that RNA viruses are smarter because they come with their own photocopy machine. Right? So in order to make copies of themselves into the host, right, or in the human body. Right? And RNA, right, viruses, right, can change. So when they enter into the human body, right, they just need to attach to the cells, and they can start making copies, right? They don't rely on the body's mechanism, right, to make a photocopy, right, of itself. Whereas opposed to the DNA, right, viruses, which are easier to manage because they need the body's mechanism, right, to create that photocopy machine for them to replicate. So it's easier to get rid of DNA viruses, right? And even find drugs and therapeutics to get rid of DNA viruses because our own body can be taught not to make the photocopy machine. And when we do that, right, the virus can't replicate. But now with an RNA virus, right, if somebody comes or a virus comes along with his own photocopy machine, right, how are you going to get rid of it? How are you going to stop it? There needs to be, right, different mechanisms, right, in order to stop it. Right? That's why RNA viruses, right, including what we're seeing now in terms of COVID and so on, is very difficult, right, to find therapeutic targets because they keep on changing, right, and they keep on evolving, right, and they replicate so fast, and so fast to a level whereby our body, it can't keep up. and it spreads so quickly to so many different people, right, that it's difficult, right, to start containing it. We are social animals, and because we're social animals, and once a virus becomes airborne, right, you can't stop it. It's in the air. It's the air that you breathe. You can't stop it. However, with HIV, on the other hand, remember, it's transmitted via secretion, so via sexual contact. Right, so that's the difference why HIV, right, has a specific vector of how it gets from one person to another. It's not airborne. It's more via blood and secretions, right? And if you can control that, and I think we've been quite successful in trying to control that, and that's why we're able to keep HIV under control. Now, with HIV, remember, right, once the virus replicates, it attacks our immune system. That's why we say immune deficiency. It attacks your CD4 cells and kills them off. So if you don't have these defense mechanisms in your body, right, there's nothing to fight infection. So you don't die because of HIV or the virus itself. You right, you get opportunistic infections because the virus attacks, right, your soldier cells in the body and the specific CD4 cells, right, which are responsible for long-term immunity and responding to severe infection. So the mortality or the death rates happen because, right, of, right, the virus attacking your immune system. Okay. Okay. Now, quickly going on to the HIV life cycle. So when the HIV virus enters the body, right, it has to attach to a CD4 cell, right, or to a cell in the body where it can hide. Now, remember, if the HIV stays outside of the CD4 cell, our body will recognize it and start attacking it. So HIV is so clever, it starts attaching to the cell immediately as soon as it gets into the body, right, and then hides inside these CD4 cells. And then once it hides, it assembles itself, starts replicating, and it releases millions of copies. Right? But by that time, by the time it releases those million copies, it's killed that CD4 cell. And then you got a million, right, or more than a million plus viruses, right, per second, right, that's starting to replicate, right, in the body. It's going to attack all your other CD4 cells. So just to give you an idea, right, is that we each, right, have on average about 600 to 700 CD4 cells, right, up to 2,000 CD4 cells with millions of viruses, right, attacking that. So you can understand how quickly, right, these viruses, right, can attack and deplete our CD4 cells in the body. Yeah. So HIV and the immune system. Now, remember the CD4 cells, right, coordinate the body's immune systems to bacteria, viruses. We exposed to bacteria every day, right? Dust and so on, right? Even in the food that we eat as well, right? There's bacteria that we take in. Now, in order to get rid of that, we need CD4 cells. Now, if you don't have CD4 cells, right, and CD4 cells are mostly produced by the gut and inside your gut. That's why, when people get sick and they start taking antibiotics, we give them probiotics as well, because that's a good form of bacteria. That good form of bacteria, right, will fight any other infection, right? So when we give you antibiotics, the antibiotics, right, take over, right, the function, right, of your white cell count, right? And what happens is that, right, those same probiotics of good bacteria are able to fight for you. Right? But remember, those probiotics, right, increase your immune surveillance, but they can't fight HIV. They just make your gut healthier. So therefore, right, you can't rely on probiotics, right, in order to build for you. You still need your CD4 cells. And the reason why you need CD4 cells is because they're specialized to a level that can attack specific bacteria, viruses, and lead the body into developing memory, right, for those viruses. So when they come and attack you again, your body has got a memory of those and can mount those specific antibodies, right, faster. Okay, AIDS. I think a lot of confusion, right, has come over time around the difference between HIV and AIDS. So AIDS is acquired immune deficiency syndrome. Okay, so when the HIV virus has taken advantage of the body's weakened state, right, and has depleted, right, the body's immune system to such a level, right, where the CD4 count is less than 200 or has a 14%, right? So this is when the body's immune system is now overwhelmed and you now present with an AIDS defining condition. Okay. Now, progression from initial infection to HIV or advanced HIV varies among people. It all depends on what subtype of the virus you have. In South Africa, we have a subtype C virus, which is readily more uh, higher replicating and more progresses to advancement more easier than the subtype B. right? So, but either way, like I've mentioned, right, is that HIV can hide in your CD4 cells. They can hide in the body, right, without having, right, to replicate. So they can sit in a CD4 cell, right, and remain dormant, right, before they start replicating. Right, so that can happen, right, for a long, long time, up to even 10 years before you even get an AIDS-defining condition. So that's why it's very difficult, right, in order to diagnose HIV until a person starts becoming sick. That became problematic. Now we've got testing, right? A person can be healthy, looking healthy, but you still need to be able to test, right, and pick up, right, whether you have HIV. So even if you are healthy, right, it doesn't mean, right, that you're not infected. The only time you'll recognize it is when you start becoming sick, and then by the time you start testing, it becomes too late because you've already destroyed a big proportion of your CD4 cells or your immune system already. So therefore, if you test, right, as part of a wellness day, right, or just between your partners, right, as well, just to know your status, right, it becomes very important, right, to know your status, because then you can start treatment. Or if one person is infected, then you can take the precautions. So that becomes quite important, right, when we're managing HIV. Now, I just put up a diagram quickly to show you the progression, right, from the time when you don't have symptoms, right, you look completely healthy. After a few years, you get maybe mild weight loss and mouth ulcers, some skin diseases. Right? But then after several years, you get significant weight loss, more than 20% of your body weight. You start getting opportunistic infections like TB. You start getting thrush on your tongue, and very specific types of rashes on the body, like circular red type of rashes which you call papillopruritic eruptions. Then eventually you move to a state of wasting where you start losing muscles. There's this chronic diarrhea that doesn't stop, and you start getting infections like TB outside of the lungs, in your bones, in the organ systems, in the brain, and so on. Right. So that's when, right, the wasting syndrome already happens, and that's when the body's immune system, right, doesn't have much CD4 cells. That's when the CD4 cells are gone below 200 already. Okay, so what are the risk factors, right, behind HIV? So unprotected sex, we know. Anal sex is more riskier than vaginal sex because the blood vessels in the anus are more, so the virus can spread more readily, right, through anal sex rather than vaginal sex. Right? If you have multiple sexual partners, right, and they haven't tested, right, then the risk of getting HIV is more. If you have another sexually transmitted infection, right, like sores and so on, that's a vector, right, for the virus to enter the body quicker, right? The use of drugs, that means you can directly inject the virus into the body, into the an uncircumcised man. So why are we saying circumcision? Now, this foreskin in men has specific receptors called Langerhans cells, and they are specific receptors that to which HIV bind to. So as soon as you remove that foreskin, you remove the receptors. Doesn't mean that you can't transmit the HIV virus via the sperm, though. It just means that the man, right, that is circumcised, right, and has unprotected intercourse doesn't have those receptors on the foreskin, right, in order to acquire the infection that easily, right? But he can still, right, get the infection, right, through the genitourinary tract or through sores, right, around his skin as well. So he can still get it. But if he doesn't have any sores, right, or anything of that sort, the risk reduction via circumcision, right, in a male, right, is up to about 65%, right, to prevention of HIV. Okay, so the modes of transmission, blood transfusions, we more or less eliminated that because we have more advanced screening, right, for that. If you have sharing needles with an infected person, unprotected sex, right, and then we need to mention this about babies and pregnancy, right? So there is a risk of infection from mother to fetus, but when is that risk higher? That risk is higher during delivery, and especially vaginal delivery, when the secretions or the blood makes contact with the baby's eyes and nasal mucosa, right, in the skin. And if the skin is breached at that time when the baby is being born, the risk of the baby getting infection with HIV is higher. So during the time of delivery is when we need to be careful, where the risk of HIV is higher in the baby. Okay, so now how is HIV not transmitted? So by closed mouth kissing, shaking hands, hugging, using public toilets, right? those don't transmit HIV, right? And doesn't HIV doesn't get transmitted by a mosquito either. Remember, it's HIV. It's a human immunodeficiency virus. It can't spread to a mosquito. Mosquito will take your blood, and by the time it gets into the mosquito and goes out, right? Mosquito doesn't put blood into someone else. They suck your blood and take your blood from you, but they don't transmit the blood back into you. So you can't get it, right, via a mosquito. Okay, HIV testing. Right, I promised you that we've got so many different tests right now. We've got the antibody test. So you know those little cassettes when you go for your wellness days, right? They take your blood from your finger and they put that on those cassettes. And those are antibody testing, right? Antibody antigen testing, right? Which detect the antibodies. So now, what's the problem with those antibody antigen? You need to have antibodies in your body first, right? And we've mentioned before that once you get infected, you don't develop antibodies automatically. So if you don't have those antibodies, those cartridges that you're doing the testing might turn out negative because your body, it could have been a recent infection and your body hasn't developed antibodies. It doesn't mean that you're negative. It means that 28 days later, right, that window period, right, you need to negotiate until antibodies established, you need to retest. So that's why we tell everybody that has those cartridge testing, right, to repeat the cartridge testing. And while you're waiting for that, right, use protective mechanisms to prevent HIV. The quickest method of picking up HIV is by PCR. As quick as 1 week, 1 to 2 weeks after infection, you can pick up the virus in the body. The P24s, the fluorescent immunoassays, Western blots are more used, right, in research, right, and for atypical types, right, of HIV diseases, right, like the human lenti type of virus, right, which is a particular type of HIV, right, where we have slow progression, right, of the disease, right, and we're picking up, right, persistent negative, right, HIV antibody tests. Right, that's when we start using these more advanced techniques to pick up HIV. Okay. Okay, so examples of rapid tests. I just put up a picture for you. So when a nurse is or a doctor is doing your test for you, right, you've got to show two lines, a control line and a test line for it to be positive. But even if it is positive, you still need to do a blood test, right, just to check and make 100% sure. Right? But if there's only a control line and no test line, right, the test means that it's negative. It doesn't mean that you could be negative. You could be in the window period you need to retest. Okay, so what can we do? Antiretroviral therapy, right? Yeah, we can give that to every person that's HIV positive, right? And irrespective, right, of their CD4 count, right? That helps, right, remove, right, the viral load and the virus from replicating, right? So what types of ARVs do we have? So as time has gone on, right, during my younger days, right, when we only had D4T, 3TC, right, and we didn't have the tenofovir, right, we were using, right, these drugs and they were very toxic. Three drug therapy that were causing liver issues, that were causing metabolic acidosis. People were developing lipodystrophy or abnormal depositions of fat on their bodies. They were developing nerve damage, severe peripheral neuropathy. But that's all we had at that time, right, in order to prevent it. And that was the barrier, right, to uptake. It was because of the side effects. So we had, right, three essential groups of drugs. We had reverse transcriptase inhibitors, non-reverse transcriptase, and protease inhibitors. Right now, over time, right, we've developed newer drugs, tenofovir, right, we've developed dolutegravir, right, fusion inhibitors, right, the newer type of protease inhibitors, right, which you don't need a fridge for. At that time, when a person failed HIV treatment, we only had Kaletra, right, and you had to put that in a fridge. And if a person didn't have a fridge, right, or if you were in a taxi traveling 4 to 5 hours to get home from a clinic, right, that medication would have expired. You would have needed a cooler box in order to transport it. Now we've got better drugs. You can take it once a day. They're combined. You don't need a fridge for them, right? And they are less prone towards resistance. And I think that's the important thing, is that we have a bigger variety, right, of drugs, and they're a lot more cheaper right now, that we have, right? But remember, in essence, we always use three, right, or more ARV combination therapy to target, right, the virus at three different levels, from getting into the body, and when it's in the body, preventing it from replicating. Right. So what's the advantages of ARV therapy? They enable recovery of your CD4 cells, and they lower the virus from replicating. So they reduce the virus, right, load in your body, right, but they increase the CD4. And then people often ask me, but why can't we get rid of the virus completely? I'm taking ARVs, right? So why does this virus still stay with me? Right? The reason why this virus still stays with us is because this virus is clever, right? It tends to hide in what we call reservoirs. Reservoirs in the body, like the testicle, right, or the thymus gland, right, or in the brain, right, where you don't have access, where the antibodies don't readily attack those areas. It's very difficult. Those are reservoirs which are protected in the body, right, that are outside or escape, where the immune system can't get to. And these viruses, like I mentioned before, they're very clever. They can go into dormancy, they can go to sleep, right, and remain there for a long time, and then suddenly wake up and start replicating and spreading. That's the problem that we have with HIV, right? Is that it can go to dormancy and stay in those reservoirs. So yes, we can get your viral load to as close to zero as possible, but we can't eliminate the reservoir infections. Okay, I'll come to that just now as to why you can't eliminate that. So that's, we increase the immune response, we decrease the replication, the person gets better, they don't have any infections, right? So what's the goals of antiretroviral treatment? Improve your quality of life, prevent you from developing infections, right, preventing you from spreading it to someone else, right, and also reduces your death, right, and due to severe illnesses. Okay, is it achievable? Yes, it can, but it's not perfect, right? They all have side effects. All drugs have side effects, right? And this is the problem, is that when I'm taking any drug, right, if it has a side effect, will you want to take it? Do you want to take it? If I'm feeling nauseous, I'm getting tummy cramps, I'm getting headaches, right? And you've got to take one tablet every day for the rest of your life. Is it possible, right, for you to carry on taking it? Right? Yes, many people have taken it, but it takes a lot of willpower, right? Right. If you have nausea all the time, right, people say, I don't want to feel nauseous. I don't want to keep vomiting. I don't want to have diarrhea. I don't want to have this pains in my tummy. I don't want to have the headaches. I've got to work. I've got to carry on with my life normally. So why should I take it? I'm not feeling sick. Right. Let me just skip it. So now once you start skipping it, even after 24 hours, the virus starts replicating and growing. That's the problem. Then what happens is that if you take the ARVs with alcohol, for example, alcohol intercepts in the liver, intercepts the drug, prevents the drug from absorbing or achieving a full effect. As a result, the virus grows. Right? So that's the problem that we're having. So this is some of the examples, right, that we have in terms of managing side effects. Right. So, and if you're sick with another infection or cancer or some other right disease, right, and if you're taking right multiple other medications at the same time, that's what we call polypharmacy. Right, it's difficult to manage those side effects. All drugs have side effects, so it becomes very difficult then to start managing, and then getting the adherence right. Right, it becomes a problem. Right. So what's the problem with adherence? So if you don't adhere, you allow the virus to replicate, but at the same time, you allow the virus to mutate. And when the virus mutates, it becomes resistant to the drugs that we have. So yes, we have a certain number of drugs, but that's all we have. Right. And if the HIV becomes mutant, right, to a specific class of drugs, right, we don't have many options later on. And as you go to second, third line treatment, the side effects become more. So the adherence becomes less, and that's the problem. And also another thing with drug resistance, if you develop drug resistance, you can transmit that resistant virus to your partner. That's the problem. So what you do to yourself, right, you can make it worse for your partner who even has HIV treatment and make his treatment obsolete. Or if they are HIV negative, your partner is HIV negative, you can give him a mutant virus, right, which won't respond to therapy, and he becomes sicker quicker. He or she will become sicker quickly. And so that's the problem that we have. Okay, so resistance can be transmitted. I said that, right? It makes the virus fitter, smarter, right, and the ability, right, to destroy our CD4 right cells, right, a lot more efficiently and a lot more quicker. Okay, HIV and COVID-19. So all of us have been through COVID-19, right? 2.5 years, 3 years, right, with COVID-19, right? Now we only had the vaccines right late in the course of the pandemic, And HIV members were disproportionately affected because why? Right? Their immune system wasn't responding the way it should be. Now, if a person's immune system doesn't respond the way it should be and attacks the virus, right, you can't contain the virus. And if you can't contain the virus, what did we speak about HIV mutation? With COVID 19, right, COVID 19 was remaining longer in HIV individuals that weren't suppressed, fully suppressed in terms of their viral load. And COVID 19 was evolving, it was mutating, right, mutating over a longer period of time and wasn't clearing from the bodies of these individuals. And by the time it cleared the body, right, it was already mutated to, right, a different kind of strain of COVID 19. And that's what made COVID 19 quite difficult, because in the cohort of HIV patients that we were treating that had COVID 19, right, we had latent COVID 19. So the COVID refused, right, to leave. And for the first time in such a long time, we've discovered something about viruses. Viruses are usually competitive, so they don't like each other. So if you're not from the same family, they'll fight and they kill you off. But now, COVID 19, as it started mutating and coming onto Omicron, started making friends with our influenza, respiratory syncytial viruses, and all other viruses, allowing them to coexist. Right? And that created a big problem for us, because nowhere in the history have we found viruses so friendly. Right? And what we've even seen now, right, is with COVID 19 initially, right, stopped every other virus, right, like your influenza, RSV, and enteroviruses, right, from replicating. So in that time, right, where you had that break where the other viruses were on holiday, they were repairing themselves and making themselves stronger. So now you notice, even what I'm seeing now in practice as well, people that are getting influenza on their own, right, it's taking longer to get rid of, right? And people are saying, no, my immune system is not good. I had COVID before, but I'm not clearing this infection. It's yes, if you had COVID before, it's weakened your immune system, right? But at the same time, the viruses have become stronger. And these same viruses are now able to recombine, which means that you can have two viruses, right, fused into each other that can wreak havoc in your body. Because COVID has now created a scenario whereby all viruses now, right, are able to be friends, right, and become a little bit more dangerous, right, for us. So that's why specifically in the HIV cohort, it's important that we give them the flu vaccines or pneumococcal vaccines in order to fight off these other viruses at the same time. And the reason being is that the recombination of these viruses that can overwhelm the immune system very quickly. Right? And that's what's going to cause the problem. And then even our vaccine antibody responses to COVID-19 as well, with individuals that don't have a good immune response, right? These antibodies, right, wane off quite quickly. Even if you had natural infection, right, the antibody responses, right, wane off quite quickly. Right? And that's the problem, right? Is that if you don't have long-term antibody responses, the same virus comes along and infects you to the same severity again, because you don't have the defense mechanism. The body's got to learn from scratch, right, how to deal with it. Okay, now I'm going to cover the social issues right around HIV. So, what are the social issues that we've had around HIV? I'm going to start from the bottom. The stigma and discrimination. In the past, when HIV, right, was relatively unknown, people were scared of it. So when they were scared of it, people that developed HIV, people stayed away from them. They didn't want them anywhere near. They didn't want, right, infections from them because they didn't know. So as a result, there was discrimination, separation. Person was losing weight, right, had oral thrush, diarrhea, and so on. Didn't matter whether it was HIV or not. People became stigmatized, right, because that was one of the hallmark features around HIV, and that's what resulted, right, in people staying away from clinics, not seeking testing, not getting treated, and then as a result, that overwhelmed the healthcare system, right, and by overwhelming the healthcare system, right, people were sitting in hospital longer, right, or they were sitting at home and spreading TB or other opportunistic infections to other people in the home. And that was the direct result of stigma and discrimination. And people weren't going to clinics to get treated. And then when the government started setting up clinics, they started making HIV specific clinics. So anybody that walked into an HIV clinic, they assumed that you were HIV positive, and they came under discrimination automatically. And that was right quite some time ago. But now all our clinics are now integrated. So it doesn't mean that an HIV clinic is solely for HIV, it's meant for everything else. Right? So the stigma and discrimination is slowly being challenged. Then we have the issue with gender-based violence. So people that were discriminated, right, or had stigma against them, right, were also right being subjected to gender-based violence. There are other forms of gender-based violence, even in HIV negative, but this was also unique to HIV and the discrimination status. What was happening is that these individuals, right, were being beat up, right, by their partners and their spouses, right, by virtue of that stigma, right, and they refused to go get care because they were scared. As a result, they got sicker, right, and they started going into hospital and they started dying. That was the social issue around those two criteria. Then it had to do with right babies born with HIV. Right, mother didn't want to tell the father that, listen, you know what, I've got HIV. Right, wanted to hide the status. Right, and as a result, went through pregnancy. Right, had the baby delivered without treatment. Right, few months later, the baby became sick, and that's when the diagnosis was learned. So because of the stigma, the discrimination, the violence, people hid away from treatment and accessing treatment. Right? And as a result, it had knock on impacts, not only on babies, but it also had socioeconomic impacts. They were sick, so they didn't want to go to work. Right? Because why? Nobody at work must discriminate against me because I'm looking sick. So how can I work? So if you don't work, what happens socioeconomically? You don't bring food home into the home. How do you feed the children? How do you feed the family? Right? How do you nourish yourself, right, and grow? You can't. And this all stems down to the 2 points. The stigma and the discrimination has led to all the other social issues, right, around HIV. And once you get health and nutritional defects secondary to HIV as well, right, and if you don't have right the money to get the good food and the supplements, right, how are you going to improve your health? So the social issues has an impact on the general overall health and to the rest of the community and the families that are living right with the individual as well. Okay, so I'll just put up another slide here around sexual and reproductive health and rights within 2025 AIDS targets. Now, in the past, we used to have right this migrant labor system, right, or we even had this concept of urbanization. So families, right, the men, right, or the women, right, would go from their villages and come into the cities and only go home on weekends and holidays. So they would work in the cities. And while they were in the cities, they used to have multiple sexual partners and develop, right, sexually transmitted infections, not necessarily HIV, right? They go back to the villages or to the rural areas and they transmit the sexually transmitted infection right to their partners, right? Because remember, again, social issue around HIV and with cohorting. Right? So if you're in a stable relationship or if you're in a home, you don't want to use a condom, right? So, and women were subjected to violence if they refused, right? The partner's will or right for him not to use a condom, right? And that's what created the problem with STIs that we were seeing in the rural areas and the perpetuation of HIV as well. So the global community, right, started seeing all of these here, right, and then tried to develop social interventions to preventing sexually transmitted infections, improving right the rights of women and young girls as well, creating that advocacy, creating the protection right for that to prevent all of that, right, and then also creating the education right, in order to save people or prevent infections from happening, and prophylaxis, right, from tuberculosis and spreading in the communities as well. Okay, so the lifestyle prevention, lifestyle, right? I always use the alphabet, right? A, B, C, D, E, right? A, abstain, right? B, be faithful. C, condomize or circumcise. D, don't share your drug needles. E, don't engage in high risk behavior. Remain, I can even go up to M, remain monogamous, remain faithful. Right? F, faithful again. All right. So the lifestyle preventions, right, will prevent HIV. They're not high, they are not 100% effective. So the condoms do burst, depends on the quality that you have, right? But now we've got better treatment now, post-exposure prophylaxis. So if you've been exposed to a high-risk encounter, you can take a tablet for a certain period of time to prevent it. Pre-exposure prophylaxis, right? We've got cabotegravir now, which is the injection which has been registered by SAPRA, which is waiting for the pricing, right, to come through. But you can take that injection every 2 months, right, and prevent yourself from getting HIV, right, just with one injection every 2 months. And that same injection that you use yourself, right, to prevent infection, right, for high-risk encounters, right, without a condom, right, you can fall pregnant as well quite safely, right, within that ambit there, right, and prevent yourself and the baby from being exposed to HIV. And so that's another advantage of the new injectable that's come through, right? And the pre and the post exposure prophylaxis is help people prevent infection. It's helped serodiscordant couples, right, able to function right within the relationship by preventing transmission from one to another. Okay, the new treatments, right? You've heard of dolutegravir. This was a relatively new HIV drug that came in, I think, about 2 years ago, as introduced to South Africa, right? Because we had this high burden of HIV and people were having side effects, right, to all the other treatments. So we needed a newer drug which was more forgiving. So even if a person missed a drug, right, for about 24 to 48 hours, dolutegravir remained in your system, right, for up to about a week or two, right? So it managed to remain or keep that efficacy for longer. So as a result, we prevented the resistance from happening. Okay, right. Then we've got the cabotegravir, which is the injectable, which would have to be taken. Right, we're just waiting for the pricing to come through and the guidelines, right? Because this is another milestone that we can circumvent. So you don't need to take tablets every day, right? If the injection comes through, right, you'll just need, right, like I've mentioned, for prevention every 2 months, for treatment every month, an injection. Okay. Then there was new treatments called kick and kill drugs. And I remember I mentioned those reservoir infections, why we were unable to get rid of HIV from that time is because they used to hide. There was a drug called TLR7 agonist that was showing promise that could actually kick the HIV out of those reservoirs and then allow your HIV treatment to kill off the virus. But that never made it to market because it did show promise. It was working, right? But I'm going to leave it up to you right, to answer that question for me. Why do you think that a drug that was working that could have cured someone, right, was taken off the shelf or not pushed forward? Right? Commercial, capitalism, greed, more money, right, in terms of treating rather than curing, right? That's up to you to decide. Okay. Then there was this, have you heard of the German patient, the stem cell transplant? Now, the stem cell transplants were, there's a certain group of people, right? I think there's about 500 people in the world with this genetic uh, uh, tendency to prevent HIV, right? So there's a handful, right, of patients only. So scientists in Europe were gathering these patients, gathering their stem cells. Now that's through bone marrow. Now, bone marrow transplantations have their own problems and complications, right? And it's very difficult, right? Very invasive. It's like a kind of a surgical technique, right? To go in there, drill through that bone marrow to harvest these cells and then to implant them. It's very expensive, very invasive, and also high complication rates there as well. With 500 people in the world able to resist with more than 8 million, right? Or let me give you global stats of 22 million people, right? How are you going to gather enough stem cells from 500 people to treat 22 million people or cure them? It's better that you get a TLR7 or a newer drug that's able to kick and kill, right, the drugs and get a cure that way, or to prevent, right, infection altogether. That's what we have right now. So stem cell transplantation has cured people of HIV, yes, right, but it's not tenable, right, or not practical, right, with so few people, right, that have that gene. Maybe future treatments, right, will aim at prevention to introduce gene therapy. I don't know. right, in order to prevent HIV from or creating that resistance or that barrier in people to resist HIV. We don't know. That technology needs to evolve, right, to that level, and research needs to go in that level, right, in order to explore those. Okay, so HIV is not a death sentence, right? There's potential cures, success on early treatment, uh, pre-exposure prophylaxis, right? But the journey is continuing. Right? So as we have the slowdown of HIV in the communities, right, and the decreased transmission, we have less people that are dying or developing secondary infections, and they're living longer and healthier lifestyles. Right? But still, right, to accelerate our impact, we need to close resource gaps, stop the stigma, the discrimination, strengthen the healthcare system, put research into HIV vaccines, put research into genetic studies, right, to build up the immune system, and into the drugs in order to cure. All right. So right now, the journey is still continuing, but right, it is positive, and we've met a lot of the goals, right, and we're still carrying on, and we're still persisting, right, in order to reach that. Right? So, right, adherence to HIV treatment has efficacy, right? It's treatable, it's a chronic illness, but you can live longer, right? You reduce the risk of transmission to partners, lower your risk of death, right? And you do live, right, a normal life, right, and lifestyle as well. It shouldn't be prohibitive, right, especially not with the new treatments, right, and the new technology in terms of the injectables coming through. So I'm going to stop there, right, and I'm going to ask some questions. Okay. Are there any questions? Does anybody want to ask?
I don't see any in the chat box, Doctor.
Okay. Does anybody want to put up their hand and ask? Yeah. Otherwise, I can test all of you. I don't mind testing. Okay.
Doctor, thank you so much for the session. I thoroughly enjoyed it. There's some major things that stood out for me. I didn't know about the what did you call them? The parts of your body that where the HIV goes and hides.
The reservoir cells.
The reservoirs. I didn't know about the reservoirs. It was so interesting to learn about that. And the new medications I found quite interesting as well. I also found it quite interesting how the viruses can't until COVID, they couldn't cohabitate. All right, we've got some questions coming through. Is it safe to have a helper who is HIV?
Yeah, it's completely safe, right, to have a helper that's HIV as long as she's on treatment, right, earlier on. Make sure she doesn't have any opportunistic infections like TB, especially, right, if she's living in your home, right. So it's important that she gets treatment, right, and that she gets screened for the opportunistic infections, right. Otherwise, infectious diseases can spread within the home. But other than that, it's completely safe, right, in order to have someone, right, in your home that's a helper there. And then I see Kate is asking if there's a recording of the session. There is a recording of the session.
Yes, there is, Kate. So if you go onto the Kaelo website, on the front page, there's a little tab that says webinars, or if you just scroll to the bottom of the page, there's a button that says webinars. If you click on there, the recording for this one will take about a week to be uploaded, but all the recordings for this year's webinars are on there as well.
Okay, and I see Ian is asking whether anything is being done to make the drugs easily available to those that can't afford medical aid. Yes, so a lot of sponsorship from the Bill and Melinda Gates Foundation, right, has driven down the price of the drugs and access to the public sector. So there's special rates. I'll give you an example, right? A course per month of ARVs cost in the government sector 60 Rand. Right, versus the private sector around what 270 Rand. And there's a lot more clinics, right, that are available. And there's even this private public partnerships between the GPs and the hospitals where the patients can go see private GPs but get the drugs or the treatment from the state. Right. So it's increased the access quite a bit. I think that's also a good initiative. And eventually what we're going to do is that if you've seen an ATM like EPSA, FNB, you're going to see ATMs now, right, where you're going to be able to correct your ARVs, right, in townships now, just with your ID card. Yeah, ID card. And they were thinking of the fingerprint system, but that'll get stolen. So you'd rather barcode, you'll get a barcode, right, which you can either take on your smartphone, right, or take your ID and scan it right onto the barcode, and you'll be able to collect your ARVs in your townships through the ATMs, right? That will be positioned directly in there for people to get access to that.
Jeez, that's brilliant, brilliant news, especially from a South African context. And there's a question here: does HIV positive not detectable mean that you're still positive?
It could mean that, right? Because remember, you could be in a window period where you haven't developed antibodies yet, right? Or you could have reservoir infection, right? So it still could be latent. So that's why, right, when we pick up, right, people that have zero uh, um, uh, viral load, right, but they still show signs and symptoms of progression of HIV, or they develop tuberculosis or opportunistic infections like PCP or meningococcal meningitis, right, or cryptococcal meningitis, which is unique to HIV, then we start looking for the other forms, right, of HIV, like the lentiviruses, right, or those rare kind of mutant forms, right, or those latent viruses, right, that are there. Yeah, so it still could be there. So you need to test, right, and don't rely solely on one test. Test again, and after about a few months or so, test again. Make sure you sit down with your partner, know what their risk factors are. Even if they don't tell you as well, educate them about the risk, right, and right, and how to be faithful, right, and how to have a harmonious relationship. I think communication between couples is more important right now these days, and we often lack that. We're so busy doing things, other things. We don't talk to each other, right? We don't spend time with each other, right? We're pursuing the material world, right? And we don't talk about things like this. And I think it's important that we start talking, right, to each other about this.
Yeah, there's almost a stigma attached to it.
Yeah.
So there's another here. What are the risks of having sex with someone who is not detectable? Someone
Someone
on
on
treatment.
less than 1%.
Sure.
Unless, of course, yeah, it's less than 1%. Unless, of course, there's another STI, right? But still, even if there's another STI present as well, if a person is fully virologically suppressed, the risk of transmission is less than 1%.
Sure. All right, that's very interesting. Is PrEP safe to use in the long term?
Yeah. So remember, pre-exposure prophylaxis, right? If you take one injection, for example, right, every 2 months. So, right, that will how many times? That's six times a year, right, so then you can effectively, right, prevent that. Or if you're having sexual intercourse, right, how can I say, occasionally, right, not every month with a stable partner, or you're only going to visit that partner after a couple of months, right, you take the injection, right, during that high risk time. So you don't need to take it, right, every 2 months, right. You can take it, right, maybe 3 times a year or so, at those
Oh,
times, right, when you're going to engage, right, in that activity, right. But the important thing is that make sure that the partner, right, is on ARVs. And if the partner is on ARVs, and for some odd reason you can't take pre-exposure or post-exposure, right, remember, you still have the other methods, right, the circumcision, the condoms, and so on. So you can still safely, right, prevent HIV via that mechanism there as well, even without PrEP or PEP. So there's many other ways, right, of preventing this. Okay.
is it possible for a couple to be married for 30 years and only have one partner? So only have one partner always test negative and the other positive, and they have 4 children.
Yeah, it's possible. It's possible because remember, the viral load, right, is so low, right, or fully suppressed, the risk of transmission is quite low. So if the woman partner was negative and the man was positive and he's fully suppressed, she can have children, right, and without contracting HIV, right? And then what happens there? Babies are born negative, mother remains negative, right? They can remain that way there for quite some time.
Oh,
And so
wow.
it's very possible, even with the pre-exposure, post-exposure prophylaxis as well, mother can remain negative, right? Or if it's the vice versa, if the female is positive with HIV, right, and the male is negative, right, he can, right, use the PrEP, right, or the PEP, and prevent himself from becoming infected and stay negative as well. Use the condom as well. Stay in the monogamous marriage. Mother takes the ARVs, gets fully suppressed. The man doesn't get HIV, so they can remain serodiscordant for quite some time and live normal, healthy lives.
That's quite promising and uplifting news for people who are HIV positive to know as well. In the interest of time, this is the last question that I think we're going to answer. How does TB affect HIV?
Okay, so remember, when you have any infection like tuberculosis, it tends to have an impact on your CD4 cells. So it destroys your CD4 cells. So in the presence of HIV, HIV is also destroying your CD4 cells, and now you've got TB destroying whatever CD4 cells you have. So your immune system is becoming even weaker. So you're going to get other opportunistic infections. And then TB, remember, right? You can get multi-drug resistant TB, right? And TB can damage your lungs. So with HIV, you can develop complications of TB, right? That can cause a chronic disease in your lungs, right? And that can give you another or secondary condition, right? TB can also go to your bones or to the brain, cause damage there as well, right? And if you're not on HIV treatment and is not fully suppressed, right, and your CD4 cells are destroyed at the same time, right, you can complicate quite quickly, right, from there. Right, so that's the impact, right, with TB, right, effect on HIV, and especially with low CD4 cell counts, right, your body becomes weaker in pregnancy, right, where you naturally lose your CD4 cells, right, and you get TB and HIV together as well. You can't mount an immune response. You can't mount an immune response. TB spreads, right, can spread and can disseminate and wreak havoc in the body.
Sure. Geez, well, thank you so much, Doctor. I think I can see in the chat box everybody does share my sentiment. This has been so interesting. Just when you think you know everything you need to know about a virus, there's some new things that come up. So thank you so much for your time, for sharing your knowledge. For everybody who joined, thank you so much for joining. If any of the conversation today did trigger you, please make an outbound call to Kaelo, to Os Nelson, or even to Kaelo Health if you're on Kaelo Health. If you have any further questions on it. If you're traveling during the festive season, travel safe, be kind to your family and be present with everybody and everything that's happening around you. Wishing you all a wonderful December. And for next year's webinars, keep a lookout on your emails. You'll be emailed early next year what your webinar topics are for next year. And we will see you in the new year. Thank you. Take care.
Yeah, thanks everybody. Happy holidays. Stay safe, everybody.